So I'm Andy McLean. I was born and raised in rural North Dakota, which is not necessarily a really diverse area, although living in Fargo, we have 40 dialects spoken here. So it's actually more diverse than one would think. I have a real soft spot in my heart for not only individuals who are marginalized, those with serious and persistent mental illnesses and substance use issues, but also for the people who are taking care of them. And my background is I was a psychiatrist for many years working with individuals with serious mental illnesses and addictions. Then administratively, I was the medical director for our state's Department of Human Services, which then afforded me the opportunity to be working with leadership and helping them to understand what the needs are and what the gaps might be. And then the last few years, I've been the chair of the Department of Psychiatry for our medical school. My introduction to disasters was personal. It was during a time in the upper Midwest when we were being deluged with floods. And there was a stretch of about 15 years that there were some extremely large floods. And in fact, one of them in the late 90s decimated the city of Grand Forks. And at the time, it was the largest pre-Katrina evacuation in US history. And so when we think of flooding, we do think of river floods. We also think of the damage that happens with tornadoes and hurricanes, et cetera. But that was my introduction. And at the time, I was also working with government leaders. And so I had a particular interest not only in individual care and resilience during disasters, but also population health issues and leadership issues. So that was my background. I was introduced to Vibrant. I was on some research with a couple of the leaders in Vibrant, and they didn't reach out to me, but my connection with Vibrant, I identified the need when the requests came out. And so I knew they were a very strong organization. I knew not only the leadership there, but also past leadership. And so I wanted to step forward and see how I could assist. So that's my background. I can go in, Amy, to my take on what it was like, or do we want to wait for the questions, or?
Let's move to the introduction of Dr. Sherry, and then we can go through the questions if that works for you. That'd be great. Thank you so much.
Yep.
Susannah?
I wanted to start off by thanking the Vibrant Crisis Emotional Care Team staff who I worked with, which was sort of some planned orientation and some catch as catch can on the phone and with emails, because I know you guys were incredibly busy. So Amy, you and Lindsay and Raven, and I could tell that situation was constantly changing where we were going to be sent. And also some of it was confidential. And so it was a challenge to really feel totally ready, maybe impossible task, but you guys were very thorough and present and available and helpful. So thank you so much for that. So I am a child and adolescent and adult trained child psychiatrist with also a background in pediatrics. And I see all ages actually, but predominantly younger people, and typically also work with parents and families. And I've been in practice for 30 years and have a long-term interest in global and community mental health. And I have done some international work in pediatrics and also in psychiatry in Guatemala and Jamaica and Brazil in a variety of roles, and in the Marshall Islands. And I've also been teaching at Harvard Medical School, teaching trainees in psychiatry, general and child and adolescent psychiatry for many years, teaching primarily psychotherapy and also child development, working with families. And I've done a lot of work in the Latino and Portuguese speaking clinics, and also some research in attachment. and teaching cross-cultural attachment. So I really have been hunkered down and working online like a lot of people in the mental health field, although not everybody, but in the last 2 years. And I had been wanting to do some more international work or cross-cultural work, and just kind of spontaneously just decided to go spend this week. And I was challenged by picturing, what can you do in a week? Like, how many relationships can you establish? How much treatment can you accomplish? And so I did feel very challenged on the one hand, and on the other hand, like it really was able to, be possible to accomplish a lot in a week. And I'm, happy to go over more about that, because it involved the challenges of being the only behavioral health providers really for the Afghan village. That is the tents that have been set up for the guests, the refugees there, who many of whom had just arrived in recent weeks and certainly months. And there had been one psychologist working there before, and he left immediately, really. And so my partner, who was great, Jane, and I really hit the ground running to be able to just set everything up, get the patient, set up a schedule, collaborate with the medical tent as needed, figure out how to prioritize people, work on how to create a safe environment, which was challenging. It wasn't like in an emergency room where you could suddenly call security, and meet many, many agencies, which to me were sort of an alphabet soup at the beginning, and also interact with the military, and then meet our interpreters and start getting to know something very quickly about the Afghan culture that would be essential for us to know about to be able to help people. So it was really a lot at once. And I felt that I learned some very important lessons along the way, which I'm happy to share. And in particular, could present some details about some very interesting clinical cases and some consult liaison successes and dilemmas.
Thank you so much. And Dr. Khan, if you wouldn't mind introducing, that'd be great.
So I'll start with the personal introduction. So I identify as a Pakistani American Muslim cisgender heterosexual married woman with a 5-year-old who dictates my life at this time. I've lived in 3 different continents, and I speak 7 languages. So issues of multiculturalism, diversity, and equity are the core of my personal being. Professionally, I'm a clinical psychologist with expertise in trauma, and more so in the recent years, it's been trauma related to immigration, colonization, disaster mental health, and refugee mental health. I currently am the director for the Center for Multicultural Mental Health at the BU School of Medicine. It's a center that provides crisis intervention and disaster relief services locally, nationally, and internationally. And I also run the Center for Multicultural Training in Psychology, which is a doctoral psychology training program, which is focused on incorporating diversity and social justice into clinical work overall. My experience with disaster relief work started after 9/11, living as a Muslim woman in New York at that time. That developed into further work and expertise that I gained over time. And I've provided disaster relief in multiple spaces, basically from a multicultural lens. So I've worked in Haiti for quite some time after the earthquake. I've worked in Japan after the tsunami. I've worked in Pakistan after the floods and after the school shootings. And I've been doing a lot of work with the refugee population in Rohingya and Bangladesh, with the Rohingyan refugees, and work with the Syrian refugees, and recently with Afghan refugee. And a lot of the local work recently has been more so focused on the pandemic, creating we have a family support center that we've created for pandemic COVID patients and their families. So I run the crisis emotional team at the BU School of Medicine and the diversity and equity related work.
Thank you.
Glad to be here in space with you all.
Thank you so much. As you all can see, we've got quite the amazing diversity of backgrounds between these three panelists. And these three represent actually a cohort of close to 70 clinicians that we have deployed ever since September of 2021. So it has been a true honor to work with people like yourselves, the caliber that you bring to provide support to our country. And we're just grateful for you all. So I would love to dive in a little bit if we could. Let's start off with basically what your role was during your time on base or on location. And then packaged into that, would love for you to share perhaps a couple of instances that speak to challenges as well as, I don't want to call them surprises, but new discoveries in your time. So Dr. Khan, I'll start with you since you finished, if that's okay, not to put you on the spot, but if you wouldn't mind just sharing again a little bit about your role, some challenges that you faced either as a clinician or more systemically, and then some discoveries in your experience. That would be great.
I mean, officially, I went in as a disaster behavioral health provider, but as is common in most disaster behavioral health settings, you wear multiple hats, and there are all sorts of unexpected roles that you take on. So I think those roles varied in terms of providing behavioral health services was one aspect of it. So I did some individual work and provided supportive services in the form of groups that I ran, as well as doing some couples work, some family related work. And then a lot of the additional work was sort of advocacy, in the realm of advocacy, providing psychoeducation and sort of information sharing, whether it was amongst teams or as staff members, providing a lot of, serving almost as a cultural broker in ways, providing those nuances based on identity aspects that were similar, and sort of dismantling bridges and gaps, sort of getting people to connect across different teams and the providers of different services and teams, and creating a sense of community. And all of that is a lot to do in a small amount of time. But I think when you enter knowing that these settings are often less structured and there are lots of unknowns, you enter with that feeling. So you go with whatever is needed in the flow of that moment. Although officially it was just the disaster behavioral health provider, but it was just sort of jumping in and seeing what was needed. So a lot of it was being connected with people who were identified initially as needing behavioral health services and supports. So working with those individuals, and then there was a lot of crisis intervention work where things were happening within the setting and being called on to go and assist in that moment. And a lot of it was like, oh, I think we need a needs assessment. Let's develop a needs assessment. Let's figure out a triage system. There is one that exists for the medical team. It doesn't exist for our team. We should create one. How are people getting here? How do we get them information on how to get here? Some of those basics, and I think that later could classify as psychological first aid, but also sort of info and setting up structures and systems. I think what was challenging, for me, it ended up being the role of interpreters. It can be complicated when some of the interpreters have had their own histories. In one way, it's helpful because they can recognize and pick up on some of the similarities of experiences, but in other ways, not necessarily always being trained in how to take that role on, and the boundaries can be really fuzzy around that. And managing that can be challenging. Some of the other aspects that were challenging may have to do with like the cultural sort of aspect of systems. Our systems are set up in a very particular way, and the cultural nuances are not often embedded in them. And when I was there, it was also the time of Ramadan and Eid coming up and all of those things, and how to make sure the systems were aware of that and incorporate that in a thoughtful way. And what was refreshing was, I think it's always refreshing for me to be outside a clinical room. We're so used to providing therapy in our clinical rooms, and just being outside in that space where you're intersecting with multiple others. It's very interdisciplinary. I love that aspect of it. And I also enjoy the fact that I was able to engage in ways that I don't get to engage in our behavioral health hospital systems. I mean, the fact that I could actually pray with a client, and I could go to the prayer room and be standing with them and doing that. That was very meaningful and refreshing. I don't get the opportunity to do that. So those sort of moments, or the times when all of us as a team gathered after the work and just went out to eat and be together, and how the importance of that, and having spaces like that built in to sort of process what you've gone through during the day. Those were helpful. And I like them not being debriefings or like, formal gatherings, but rather opportunities to just connect informally. Those parts were very valuable.
You spoke to a couple of things in your answer, which I think are really, really critical to highlight. They're the one that's sticking out to me most is what you said about community, right? And helping, and that is very much a part of like the psychological first aid kind of infrastructure, right? But I think, for those of us that are the caregivers, oftentimes we forget that community building component in the heat of crisis response, right? So because we're just trying to get done what we can given the limitations, but how critical it is for us to have those people that we can just exhale with, or eat food with, or pray with, or whatever it may be, and helping connect people to that, or remind them of the existing community that they may have, that in the throes of whatever crisis is happening seems to feel really far away at times, and for these individuals physically far. So I just wanted to highlight that, because I think it's just such a critical piece of all of this. So Dr. McLean, I'm curious about your answers to those questions. Your role, you were at a very different location than Dr. Khan, and I think you were right at the turn of the new year calendar-wise. So I just would love to hear from you.
So my role, Amy, was as a psychiatrist, and since it was a little bit later, we weren't always putting out fires, and so I had a little bit of extra time to look around and see what the needs might be. And so, I think that was helpful for me to be able to go and talk with some of the providers on their own care, on resilience, and then also on talking about mental health with the guests. Being a physician, reminding them, we don't want to over pathologize normal responses. At the same time, we do have to keep in mind that people can become quite ill, and there can be a lot of overlay with somatic or physical sorts of illnesses. And so I was able to also do some education and instruction there. I think it's always important when one is going in to remember that you're a guest along with the other guests. And particularly when you're on an army base, or when there are rules and regulations, and so it's important to be mindful of that. And fortunately, I've done some work in corrections, and it's just another reminder that there are rules in place for a reason. At the same time, I think all of us who volunteered, we certainly have some level of expertise, and as Dr. Khan said, we continue to learn. But I think one of the challenges is, even though there's an expectation, you have this task, you stay in your lane. I think having expertise, it's important to also look around and see where the gaps are, and where other ideas might be helpful, and to go ahead and let leadership know that they're not expert. And so if we have thoughts and ideas and experience, I think it can be beneficial if in a respectful way, we let them know that these are some things that might help them to lead even better. And so those were the sorts of things that I had the time to do, and so did that. The other challenges, when you go in, and as Dr. Khan said too, you have a week, and what can you do in a week? And so you have to actually figure that out pretty quickly, but also be flexible, as the needs can change hour to hour, day to day. One of the challenges that I had was, figuring out the players and the layers. There's so many different organizations that are in. I don't know who they are. We had organizations actually organizations that were two of the same group that were doing something different, and people would use the name and I would think it's one thing, but it was another. So that was part of the challenge too, is trying to find out who all these people are, what resources are available, not step on toes, and try to link as a team as best we can. So those were all challenges, but people were being flexible also, and I think they were just appreciative. The other thing that Dr. Khan had mentioned in terms of community and outreach. So when I was a psychiatrist, I used to do a lot of in-home visits and a lot of outreach, and that's so helpful to be able to go and see what people are experiencing, what their living situation is like, and to be able to see what sort of resources they have there, and so not only is it good to get out of the office, but it's important to do that as well. And we did that safely, and we had guides and we had interpreters, and people. One of the things that I was struck by was the guests were extremely appreciative that we did that. When we did show up, when we did come out, and it was very clear that many were not going to come in to see us, and so there were opportunities just to engage. And maybe one of the leaders of a particular group might be able to identify, well, this person isn't going to come in, but could you come back and see them, at this particular time? And so being flexible in that way, I think, was really important. So I think the challenge is trying to get as good a lay of the land as you can, and figuring out what the needs might be, figuring out what your role is. And then, our job is to not only help those individuals, but also help the people that are in charge of helping those individuals.
So you said something, Andy, which I would, if you don't mind, I'd love to just kind of dig into a little bit with you. You mentioned navigating the environment and the different, actors in
Right.
any scenario, and that isn't unique to the situation that you guys deployed in. It actually is a fairly common reality of crisis response, disaster response, and sometimes even just caring for a patient. So can you talk a little bit about the posture that you kind of work yourself into as you're navigating? Like what does it look like? And I think in probably the most practical sense of the word, to navigate, like what are some tools or practices that you deploy to ensure that you are moving in a way that builds camaraderie?
Right. Well, the people that I was working with had been there a while, and so they had a lot of information as to what are the resources, what have the issues been for you, who have you talked to about it. One of the challenges was too, even the representatives on the base, they were changing, and so it was kind of like trying to track and figure out who next do I talk to. So I think that was part of it, though, is to try to identify to where the answers might be. Do I have an avenue to be able to communicate with them? For myself, one of the places where I was able to do that was with the clinic and with the medical director of the clinic. And so I think establishing myself as being user-friendly, I think was helpful in having that communication, and then also the links to different places to find that information in terms of the navigation in that very short period of time. You and I talked, Amy, before about the challenges in the guests who are getting medical care, and we don't have really thick charts or a lot of background, a lot of information. We're doing it on the fly. Some we have some information, but I as often as I could, I would try to link with the clinic, because oftentimes that was where I was going to be able to connect with the guests, or at least have their providers connect them with us, but also to be able to find out what was needed that wasn't being met, linking the behavioral health with the primary care.
Yeah, thank you. And I think that's something, we have talked about before, for the audience, how often mental health and primary care are seen as two distinct things, But when they are overlapped and when there's consideration for the whole person, the effectiveness of care is that much stronger. And it's definitely something to be considered when serving marginalized communities, because there's often a lot, and for good reason, in historical systemic issues, there's a lot of disconnect, right? So,
and there are many cultures where, talking about mental health is not really something that's done a lot, and sometimes we often see symptoms being, aches and pains or somatic or physical, as opposed to articulated with, Dr. Khan or Dr. Sherry probably wouldn't have people come in and say, I'm very emotionally distressed and this is my problem. I have this neuroticism, blah, blah, blah. It actually gets manifest in other ways and we have to figure it out.
Right. Thank you. All right. So Dr. Sherry, would love to hear from you a little bit about your role, challenges that you faced, and you had mentioned a couple of stories that you'd like to share, and would love for you to do that.
So I've heard a lot of echoes in my experiences so far today. And I would say I thought of my primary roles as to consult and collaborate with other people in the work they were already doing and provide clinical care to individuals, or if I had a chance to groups or families. And it wasn't that easy even to decide, to figure out how to embark on that and how to maximize, my time to be able to do that. So I just tried to keep track of all the individual relationships and all the agencies and what they all were doing, and realized that the people that I could form the relationships with were going to be the most helpful. So I'm sure there was a lot of people doing a lot of important things, and we attended meetings, we met them, but it turned out certain individuals were much more keyed into us. And so we were ready to respond to them. So I went to some group meetings of women that had very open, variable agendas, where I was introduced, and I was very glad there was a receptivity to my being there as a mental health provider, because I also wasn't sure if there would be or not. And so everywhere I went, and my partner too, we'd say, we're available to help out in whatever way you might be able to use us. And that included psychoeducation, so that somebody wouldn't have to say, I feel like there's something wrong with me. We had a concern people maybe would, have that stigmatized. And so also I was invited to the classroom and did a sort of general stress management talk. And that was helpful too, to get hooked up with the education people. And so most of our days, once we were able to figure out a way to get patients into our clinic, were spent with individuals who needed help very acutely. And there was really a range. And along the way, we figured out how to document some information, again, there's no chart file, to document some information that we could pass on to some people in the medical tent who wanted to know who was most acute and what was going on with them. And that's especially with regard to who might emergently need the hospital. And so one of the challenges that I found in terms of collaboration involved our consultation on a baby who had been burned. And I was part of a group, and I didn't exactly know who was in this group, and everyone got introduced, but I still didn't really know what their role was. And I said, well, has the family, the parents, been evaluated, in the sense that, sometimes if you put a baby who's been injured back into a situation where there's either neglect or, a lot less commonly, but intentional abuse, there's a bad outcome. But one of the other members of this group said, well, what is this, some kind of witch hunt? And, obviously I had ruffled her feathers, and I wasn't sure if she felt that I was, I had the sense that it was maybe, you're just here for a week, and who says you have a better idea than I do about how to do this? So I'm not sure if that's what it was, but I knew the importance of sort of developing a whole series of hypotheses and trying to be firm and clear and open all at the same time. But mostly people were very receptive to the kind of help and ideas that we had to offer. So another that also tapped into this challenging cultural aspect of a lot of the work that was going on. And people talked about this in small groups in different ways, which was the idea that the people who were arriving there had disciplined their children and been watching their children a very different way. And the way it was put to me was, they're at very high risk to be notified by the Department of Children and Family that they are either neglecting and or abusing their children. That's separate from the other story that I just told, which was very specific. And so a lot of the education for the families, a lot of what they were doing in the classroom actually was teaching English and saying, if you do this, if your kid runs out and hangs out in a playground at certain ages without your watching them, you'll be in trouble. Or, if you discipline them in the customary way that involves something physical, then they'll get called. And so there were, I was trying to figure out, how can I talk to people about this, because I had several different mothers that came in very worried and very upset. I'm going to tell you about a couple of cases that I saw that were kind of overlapping with that. One was a 10-year-old boy who had passed out, and he wasn't eating. And so pediatrics had sent him to us. And so I met this boy. He looked younger than his age, and he was with his older brother. So like most of the people there, they had suffered this multitude of traumas, and that was separation from his parents, not knowing when or ever he would see them again, not being able to plan anything at the airport, and actually witnessing people get bombed right next to him. So that is fearing for the loss of his own life, and also seeing this really horrific and traumatic, gruesome scene around him. And, so this was really a main agenda for everybody that walked in, was how to help them tell their trauma story and do it in a way that met them where they were, that would help them feel shored up and not more distraught on leaving, or not feeling overly probed. And so what was really helpful with him was something that we do a lot in child psychiatry, but there was a lot of, I was doing that was improvising, and it was making a family tree together and helping sort of reconjure what his family really involved and looked like when he was home, which was many, many siblings, most of whom were actually grown. And then also helping them and myself realize along the way that they were, for a long time, probably were going to have a newly constituted family group. And that is what a lot of people do in traumatic situations, is reform small groups that play the part of what their family members used to play. And so now his oldest brother was really going to become a parent to him. And then I helped also the oldest brother understand that, although he's very loving and kind, he hadn't really appreciated that his younger brother's role as the baby of this big family was really being kind of displaced by his own children. So something else that was really useful was how ubiquitous, of course, cell phones are. And he could, in addition to giving me a history about this boy, he could show me images of the boy dancing happily with they were really his nephews, but sort of the same age. And so I helped him think about how he could get images of this boy who is partly a hunger protest and partly being so depressed and traumatized that he stopped eating, that he could get images of him, not just his nephews, with his parents. And could he put them by his bed and be able to open his eyes and see himself with his parents? And then we also just did some drawing, and I thought the boy maybe wouldn't communicate at all, but he communicated a little bit, and he said he missed working with his father, which is also not something typical of somebody who would, be 10 years old. It's totally possible here, but it wouldn't be the first thing I'd think of if I said, guest, what would you answer? What do you miss the most about home? And he talked about being a serious assistant in this store that his father owned. And then he drew some pictures, which felt very helpful in terms of his communicating his story. And one was of his family car, which I think said something about that his family was well-to-do enough to have a car, and maybe something about this journey that he was taking. And then I was able to have a follow-up with him, and I was very pleased to see he had started to eat again. And we also talked, of course, about nutrition and pediatric follow-up, but he wasn't in the same danger of passing out. And he drew a picture of a hungry cat, and he showed that he was more in touch with his own hunger and really able to communicate about that. And like a lot of the people who left after their session, he left with a much lighter step. And none of that could have predicted exactly, you know, about in terms of a manual or protocol. It was much more tailored to the individuals. And another example I could say in a more streamlined way was that a woman who came in, who I had met in one of the women's groups, with a big smile that seemed a little artificial. And she had a conversation with the interpreter, a lot of which I couldn't follow and wasn't interpreted. And the interpreter said, "She's in the wrong place. I told her she should leave." And I said, "Well, what, if you don't mind my asking, what did she say?" You know, because I really both respected the interpreter's work and plus their experiences, and their being members of the same culture, and also felt sometimes there was a tension between their wanting to interpret everything and what they had selected out that they thought was important. So she really felt that she should tell this person, "Don't come in here." And the person had said, "I got you mixed up with someone else. I thought you were the one who taught relaxation exercises." And I said, "Well, why don't you tell her I also do teach relaxation exercises, and she's welcome to go, but if she wants to stay, we can do some together." And so the women decided to stay, and I asked her to describe what she had learned already so that I could again kind of meet her where she was. And so we embarked on this relaxation exercise that started off the way hers had. And I added some positive visualizing imagery and said, "Can you picture a place where you feel really good and really safe?" And she burst into tears and just started sobbing. And so we were able to talk about that. And I knew that at that moment, you know, we were at some risk of this feeling of my having kind of opened up a floodgate that perhaps she didn't want opened, or in our very short time period we couldn't help with. But she was able just to describe a beautiful garden with her family members in it. And again, this had a lot to do with family separation and worry about what would happen to them and when she would ever see them again. And it was, a lot of it was really her telling her trauma story. And so at the end of that time period, she went out again, much lighter step and more of a kind of genuine expression of more relaxation on her face.
Thank you for sharing. I think, you know, something that stood out to me in those stories is really, regardless of method, really empowering the person that you're connecting with to own and express their story in a way that feels safer than, and even just having the space, someone to listen and truly listen without any particular agenda or need to follow up or analyze, right? So I think that is a really important piece of this. You know, Dr. Khan, I'd love to hear from you a little bit as well in this next question, which is, when in this particular deployment, and maybe even perhaps linked to some of your experiences abroad, if there is a connection, there may not be. When did you feel most utilized in your capacity, and whether it be the clinician or the advocate or the different titles that you gave yourself? When did you feel the most utilized, and what contributed to that, both personally and then externally? Would love to hear your thoughts there.
Yeah, it's hard for me to think of it in terms of like when I was most utilized. I mean, in different ways, I've utilized differently in different times, but maybe one example that captures bringing together the role of a clinician as well as a cultural sort of aspect of it, and helping with the system as well. So I know in one of the crises, encounters where I was called in because there was a domestic violence situation that was reported. I had to go to the room to help for that. And I walked in, myself and the interpreter, and there were 3 kids and the mother and the father. And there's a lot of ruckus, and the mom was like, I'm leaving, I need to leave, I need to get out of here. And then security had been called in, who was sort of taking away the father figure and trying to separate him. And there was an automatic assumption that the male figure was trying to, there was a domestic violence situation. It was a man who was trying to hurt the wife. And it ended up being completely different. The mother was upset and was just really agitated and wanted to go back. She didn't want to be there and wanted to figure out how to get back because she needed to get away. And the interpreter was like really upset, and the children were crying because they don't want the mother to leave. So you have to de-escalate the situation and trying to separate them all. It was complicated. And the interpreter jumped in and took the role of like, you cannot leave, these are your children, you can't do this to your children. And, you know, out of genuine attempt to help, and just getting her to separate, getting the husband to separate, getting the children outside so they're not encountering that. It was just, you take on the role, you can't do the clinical work necessarily in the way that we think of it. You know, de-escalate the situation. So it was getting the husband to separate and go into a different room, getting the children to step out and say, your mom is here, she's talking with me, don't worry, nobody's leaving, getting them to step out, getting the interpreter to stop and like, you know, let's just interpret, tell me what, you know, what she's saying and I can repeat. So it was just really de-escalating all of that and learning that the mother wanted to go back because her mom was dying and she felt like she would not get to say goodbye. And no matter what, you know, she needs to leave. And the husband was feeling he was shot in this whole process of being in a fire, and he was hurt in a major way. And he was disabled and he felt like he was a burden on her. She was the one who took care of everything. And if she leaves, what is it going to mean for her? And the kids were listening to all of this and feeling like mom doesn't, you know. So there's so many multiple feelings, and just getting her to explain all of that and recognizing that she was on medication before. She had a diagnosis of a bipolar disorder, which is uncommon that they actually had that and know that she was on medication for it. And getting all of that sorted out in that moment. I think once she was able to calm down and listen and explain what she was going through and acknowledging like, that's gotta be difficult. I understand you want to be with your mom, how challenging. If you really wanna go, you have that option, making it, you know, open so that they have options and choices and it's not restricted, and just bringing her downstairs, talking to her separately, and then going to the husband, talking to him separately, getting to understand his story, getting to the children and saying, you know, this is what it is, don't worry about it. It was so complicated. But I think once she was able to calm back down and recognize this was her choice, and husband was able to engage and sit and listen rather than just responding and trying to stop her, they were able to be together. And he said, if you really want to go, I wouldn't stop you, but I feel like you're leaving because I'm so much of a burden on you. And she said, no. And then she was able to bring up her emotional part. And no, I really care about you. You've always been so supportive. And he was feeling a lot of things because the security was stopping him as if he was abusing her. And she said to them, actually, I pushed him and I've done these things a couple of times, but you assume that he, you know, they were assuming that's always the male subjecting the female to that. And they were able to reconnect with each other. And he was able to say, if you really want to go, but you know, what would it mean for us? Like, would you come back? How would you come back? Getting her to understand the practicalities of it. A couple of days, she was able to calm down. We met 4 or 5 times. And she then decided she did not want to go and she wanted to stay back, but she needed to know that was an option and you would have these choices, because historically she's never had choices and things are always dictated. And it was the idea of having that freedom and choice. Getting her connected to the medical services, getting her medication, getting her started on medications, And then bringing the children in and her being able to connect with them and explain, oh, I do care for you, because there was a 13-year-old, one of the kids, and she said, the husband was saying, what are you going to do when what's going to happen to them? And she said, I don't care about them. They can go. And the 13-year-old was very angry and upset. I was not been talking, bringing her into the room. And the mother saying, I'm sorry, I don't mean that. Of course I love you. And just coming back together as a family and reconnecting, doing the individual work, and then the couples and then the family together. It was just really, it was nice to see how all of that could come together, but it also meant having some conversation with the interpreter, getting them to understand, you mean to help, and you have your own children. That's so hard. I can't imagine you trying to do the right thing. But sometimes de-escalation helps. So this is what the process is. So it just felt like a role that, in which you're teaching, you're providing psychoeducation, because the medication, they thought they can just go out and get the medication because they had been able to buy the medication from a pharmacy. They don't have to see anybody. Getting them to understand those parts. It's just an example, I guess, that comes to mind that captured the different roles that you can be in and felt like was productive and to it. And then I remember speaking to a Dr. McLean was just talking about, many of them don't want to come in from behavioral services. So when I gave them future appointments, they came in, the room was closed and it said behavioral health, mental health service. They're like, the husband created it. We're not here for this. It's not what we're coming in for. We're here to see Dr. Khan. We're not coming for this. Not recognizing that what I'm doing may be that. And we quickly changed that to supportive services, remove the, how we were identified. And once he saw I was inside, I was like, oh, you're here? I was like, well, this is support services. This is what we do. It makes our health better, mental health better. So he was able to then come in, but the idea of what mental health meant was very, obviously stigmatized. And but there's some psychoed we could even provide around that. Like, you can tell other people, you can get this sort of help. It's okay. And that example came to mind as you asked that question.
Oh, I have to echo what Mitchell said in the chat. It's like an incredible story, and all mediated through an interpreter. And for you to be navigating the care of that family, also the care of that interpreter, who likely, from at least, in the moment, in that heat of it, kind of lost sight of role, and that can happen a lot in these crisis moments where the desire to help or the desire to move things along can put blinders on to the actual needs. So it's just that, again, so important to have buddy systems or people around you to kind of help bring back and anchor us back into the roles that we've been asked to have in the moment. So Andy, I would love to hear from you too. Same question, when you felt the most empowered or useful in your role, if there's a particular story that comes to mind, and then I'll turn it to the audience for any additional questions.
Sure. Well, as I mentioned before, I think helping the providers, I think, was certainly gratifying. One situation that unexpectedly came up was, so we were on a military base, and one of the individuals who was covering for reception came back and said, I don't know what to do. Can you see this person? And so I went back there, and lo and behold, it was actually a soldier who was brought in by his commanding officer. And they have a procedure where they're supposed to, go to their providers and that link, but it's a not very fluid system. And it was clear that there was a crisis. And I explained to him my role, and I didn't, treat him as a psychiatrist would to another individual, but we problem solved. I said, sir, I'm more than happy to talk with you and your officer about what's going on. Maybe, and so we came up, I think we helped him process. We came up with a very reasonable plan. And so it was kind of like, I understood what the rules were, but at the same time, a crisis is a crisis. And, we were able to work things out to where it was, it wasn't disruptive to the system, but it was helpful to that individual. And so I think, kind of a no wrong door kind of approach. And also I always remember one of the Menninger brothers, often said, when in doubt, be human. And so, that's a helpful reminder there too.
Yeah, we actually, one of the first things we say in orientation in our module that we offer is be human first. And just remembering, and again, that can be so challenging when you you come to the table with training and theory and expectations and structure. But that anchoring in this person having an experience and not approaching it necessarily from like a diagnostic perspective, but from a just humanity is super helpful in the journey. I definitely have seen that along the way. So one of the things that we talk a lot about, I think in behavioral health in general, is this concept of self-care, which candidly, I feel has become a bit buzzy in its in its presentation, though definitely not in its importance. Wanted to kind of hear from you very practically 2 or 3 things that you do as a care provider, caring for the people that you do or have. What are 2 or 3 things that you implement in your self-care plan to ensure that you're coming from a place of fullness and health, I'll say. So Dr. Sherry, if you wouldn't mind sharing that would be awesome.
I brought tapped into some online exercise classes. And at the end of every day, I was so tired. I could barely do them. And when I came home, I also learned I did have COVID. So that I think that I was tired from the work and then it segued into COVID. This is just at the beginning of Omicron. That was a whole nother story about what was going on with regard to that in different parts of the country and right there on that base. But it was really important to have a very lovely and collaborative partner and to share a lot of our experiences with each other and to feel safe together. And then again, some other people that I met and identified, I felt, really close to pretty fast when we found ways to trust each other and work together on some urgent situations. And so sharing our responses to that. And also enjoying our meals when we had time to eat them, which was really mostly dinner. So grabbing something along the way so that we weren't also passing out like that boy, but really at the end of the day, being able to just sit down and in a mindful way, really be calm as well as processing what we have been through and eat well and sleep well. The basic self-care recommendations are so important.
Sorry, Dr. Khan, how about you?
Can I just preface it by saying I'm not really good at self-care? For me, the notion of self-care is a very westernized notion. The idea for me of self is so embedded in sense of community and togetherness that I think taking care of others feels like self-care time. So that's why I'm not good at doing it. But I've had to incorporate that, and it does make a difference. So I think, like I was saying before, I think being with the team members thereafter and having a meal together, those sort of like moments were very helpful. I think just being light and being able to laugh and sort of counter the intensity of the day with something that felt enjoyable was really beneficial. And I thought also, I think, being in touch with my daughter. I was seeing a lot of children going through so much, and it was taking a toll on me, and I felt the need to be connected with her. And just hearing that she was okay, and also being grateful and appreciative and recognizing my privileges and how that's not always in place and can take it for granted. And how those sort of things were helpful in terms of situating myself and being more ready to do the work again the next day. And like Dr. Sherry said, I think the very basics of eating and sleeping, is important. And I tend to write a lot. So, every day I was journaling, and whatever happened during the day, it's like without thought, trying to not use my mind, but just let out whatever was coming in. that felt like a good outlet. It's also interesting to look back at it later and see what I was thinking, feeling in that moment. So,
sure.
That helped.
Those are great tips. And Andy, we'll close with you.
Yeah, just touching base with family back home. I think it was important to know that they were okay. And the other thing is, sleep is always important to me. And so regardless, I try to get adequate sleep. And then I like to just do crosswords and mindless sorts of things in the evening and take my mind off it. And so that ritual is always useful for me. So.
Yeah, thank you for sharing. And just want to say again, thank you so very much for your time this afternoon, for sharing your experiences. I know we could probably go on for another hour talking about some of the things that happened during your time, but just thank you again for giving your time and your service to these amazing people who have a lot ahead of them, but you've done amazing work. So thank you for being a part of our cadre.